Welcome to Take 3 and Call Me in the Morning, a podcast where three doctors from three different disciplines cut through the noise and bring nuance and practical insight to conversations about health that actually matter in our day-to-day lives. I'm Vahid, a physician, and I'm joined by Pegah, a doctor of clinical psychology, and Adam, a doctor of physical therapy. We bring our perspectives together to connect the dots and tackle the questions, trends, and everyday issues that can leave people unsure of what to believe or what to do next. No gimmicks, no fads, just real conversations grounded in evidence, experience, and a dose of common sense. In this conversation, Adam and Pegah explore the concept of no pain, no gain, and its implications in both physical and emotional healing. They approach this through the lens of each of their areas of expertise. The conversation emphasizes the need for self-awareness, the complexity of pain experiences, and the importance of self-compassion in managing overwhelm. They conclude with reflections on personal limits and responsibilities in the healing process. I hope you enjoy.
Hello, welcome.
Hi, everybody.
We have decreased our dosage from take 3 to take 2 today. It is myself and Pegah.
So does that mean
today?
Does that mean that the two of us are more intense to make up for the third?
Yeah, I feel like we have a higher bioavailability between the two of us. So we got to be mindful of the dosage there. But
so
absolutely.
Can you define bioavailability since you're talking about it and 50% of the room doesn't know what that means?
That's like in pharmacology world, that's a like pharmacokinetic metric. So if you take, depending on route of administration, if it's like IV versus inhaled versus oral, there's different percentage uptake of the medication. Yeah. So I think like inhalation and IV is the highest. I don't know. That'd be a Dr. Vahid question, but
Gotcha.
yeah.
I like to think of myself as bioavailable. That's cool.
Are you gonna start putting that on your dating profiles?
Yeah. My level of bioavailability.
That's not a bad idea. Where's Match.com when I need it?
I know. Exactly.
Well, today we have a interesting topic that I would like to start with you on and kind of go more towards your world. It's pretty apparent in my world, but the topic of no pain, no gain, and what does that actually mean? Kind of the myths behind it, and how do we perceive that as practitioners?
Great.
So I will let you start if you're comfortable with it. So actually, let me ask you this. What's your knee-jerk reaction to me saying no pain, no gain?
I think of like some coach in high school that says, keep going, keep going, keep going, even if you're exhausted, even if you're like hyperventilating, even if you're weak, just keep going because that's the only way you're going to get strong. And then it freaks me out and makes me want to run in the opposite direction.
Oh, so you have a fight or flight trigger with that one. Yeah.
Mm-hmm.
I think most people would feel the same way as you do. I certainly think of a coach as well. And I think that when I was doing a little bit of research into the origins of it, I think this is more of like a 1980s bodybuilder scenario.
Yeah.
But unsure. But you know, my patients say that all the time in here whenever I ask them if something's uncomfortable or how it feels, and then their knee-jerk response is no pain, no gain. And I don't love it. I don't love it. So I certainly know how I feel about it and what that means to me in physical therapy and how I educate my patients on that. But I'd love to hear your thoughts around what you do. And if this is even something that comes into the picture, the conversation between you and your patients.
Yeah, and I'd also love to hear what it means in your world. For me, it's always a balancing act. You know, folks are coming to feel better for lack of a better word, emotionally. And so I do like to look at it through the trauma lens because it's just makes a lot more sense to me. You know, folks come in with symptoms of anxiety, depression, whatever those symptoms are. And then what we're typically doing is we're going, what's the origination source of this? Where did this begin? How have you adapted to the experience of what happened? And so when we think about how have you adapted, a lot of times one of the main ways people adapt to trauma, and it's right there in the symptomology of PTSD, is avoidance. And so it kind of gets you to this broader topic of approach versus avoidance. And the default response when we've been injured emotionally, psychologically, for a lot of people is to avoid. And that actually creates a lot of the issues that they're struggling with. So the balancing act in my world is to determine at what point do we decide approaching is more beneficial to the system in order to help them heal than avoiding. Now sounds like an easy enough question, but the idea of approaching needs to be taken in doses. And we talk about titrating with approach, whether it's a memory or it's a situation. And then the other thing I think that's important to name, which I think you kind of brought up with your clients who say no pain, no gain, is the idea between pain and discomfort. And how do you define the difference? How do you know the difference between I'm in pain and I'm experiencing discomfort? Because with discomfort, you can continue to stretch. With pain, there's information there that's asking you to back off.
Yeah. And we have all these systems in place physiologically to help us alert to pain or discomfort or any sort of thing with potential negative outcomes. We are very well versed with all of our different senses to incorporate that into our psyche, right? So is there anything with what you do where you would say pain is a necessary part of the healing process? Do you have any examples off the top of your head where it's like, because I know I do it in my world.
Yeah. Well, why don't you? I'd love to hear your version of this because I always think there's such an overlap between the psychological and the physical.
Yeah, it's a pretty broad subject in my world, and so steer me away from my tangents on biopsychosocial model of pain. I'll try to keep it specific to the question that you asked and the topic we're going for.
And if I start to get overwhelmed by you going kind of into the nerdy land,
yeah,
I'll just sort of knock and say, "Hey, Adam, come on back here. You lost.
let's have a safe word. I think it should be flabbergasted.
Okay.
Yeah, just yell that out if
Fair.
I'm going into left field.
Okay, flabbergasted. Got it.
So to your point, yes, there's certainly good pain and bad pain. Even in some cases, there is certainly some purpose to the pain. So as we always say, it depends on what's going on who the person is, on the situation, right? You could be doing the same exercise one day and it feels totally pain-free and fine. You could do that another day and it is incredibly painful. So we have to consider environment and situation and fatigue and physiology and rest, recovery, all of these different factors to understand, is this good pain, quote unquote, or bad pain? Is this purposeful pain or reductive or destructive pain? So I'll give you an example of something where we would want to see some discomfort, and that actually helps guide our dosage of intensity, would be something like a tendinopathy. Tendons are very thick, strong tissue, and a tendinopathy is essentially, if you looked at it under a microscope, you would see disorganized tissue, right? It's not nice parallel fibers.
Mhm.
So the thing that's usually more of a chronic type of injury. So the thing that will help alleviate that is literally pulling that tissue back into alignment, and that requires heavy, and typically very slow tensile force or resistance.
Yeah.
And we grade that. We that's part of the treatment algorithm. Is okay. There should be some discomfort here. We want to keep it within bounds. We don't want to go too high, but we should feel some, because that's how we know we're loading it properly.
Right.
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 Whereas on the other side of thing might be acute nerve irritation or inflammation. That we want to be a little bit more careful of, because that is causing pain because there's a lot of inflammatory metabolic byproducts usually around the nerve sheath itself.
Mm-hmm.
So we're not doing any good if we're, say, putting some stretch or strain on the nerve rather
Right.
than flossing it or something.
Yeah. Yep.
So yeah, so
So I'll pause you there and see if I can kind of weave it in. I like to weave it in with what you're talking about. In the work that I do, the sort of what people don't really know about what it means to actually process trauma, in order to get to the other side, is you actually have to move through. You can't go above, you can't avoid, you actually have to go through the trauma experience and the memory. And when you do, the body responds sometimes with what some different kind of ways of looking at it is with what it couldn't do before, it does. And so that's how you know you're moving through the trauma memory. Or the individual may have all of the experience that they had then. But the most important thing for my work with my clients is how we set the stage for that to happen. So I imagine that's very similar to with tendinopathy, is like you kind of have to do a lot of work before the work in setting the stage for, like you said, pulling the tissue and then putting it back into place. I kind of think about that with other forms of, kind of healthcare, medical world where, you go in with a deviated septum and they have to kind of do some breaking up in here, even though, Dr. Vahid's not here. I imagine there's some breaking of things up in your sinuses in order for you to be able to breathe.
Yeah.
So that kind of thing happens in our world too. It's like we're looking at going, okay, this is a terrible thing. And the only way through to get to the other side is through, and it's not going to feel good. Now, how do you distinguish that between, like what you were saying, acute? I like to write these things down when you talk about them, like acute tissue damage and pain versus the necessary course of treatment to get to healing. And so in our case, the way we're looking at it is when a person can become too overwhelmed with reprocessing trauma, then we have to, again, turn it into bite-sized pieces, titrate the material, go into the memory and come out of the memory, again, set the stage. In for example, one of the other types of treatments that are out there, it's called exposure with response prevention. It happens a lot for people who have anxiety, phobias, where they have to actually get exposed to the very thing that they've been avoiding. So remember approach avoidance that I brought up at the beginning. And so, but the way you do it, we call it a graduated exposure. So you're not going, you're afraid of spiders, let's put a spider on your lap. That would be too overwhelming to the system, and they would hit fight or flight overwhelm. You lose them.
Yeah.
You basically re-traumatize the person.
Yeah. Do you think they're getting accustomed to the discomfort more, or they're moving past it or breaking through?
That's such a good question. The word accustom is a good one. I think that's actually what I do. I think I am in small bits and pieces, exposing my clients to their own discomfort the minute they walk in my door. So with little exercises and activities, I'm starting to teach them that you have to get accustomed to. Now, that usually what they're not accustomed to is the discomfort in their own body. They're tending to avoid the discomfort that comes up when I think about this memory, or when I'm, having to do the difficult thing of speaking, communicating directly with my partner, or whatever the case might be. Is what I'm actually helping expose them to in bits and pieces is notice what you're feeling in your chest as you talk about that. Some people have never done embodied practices like that, of noticing where the discomfort might be in their body. But the capacity, so in my world, the capacity to observe the discomfort actually manages to calm the system down. It's kind of like when you bring from fight or flight window of tolerance, to observe the discomfort in the body actually helps you to come back into your window. So that's a skill that a lot of people don't have. They don't have kind of the literacy around it. They don't really know that.
I was just wondering, as you were saying this, do most people come to see you because they are feeling some sort of way and they've recognized that what they're feeling is painful, or is it more external? Maybe a significant other has noticed something, behavior or actions. Where do you see that? And depending on what stirs them to make an appointment with you, do you direct your plan of care based around that? Does that question make sense?
Yeah, I mean, it's probably similar to you, right? Like they come in and say, "Hey doc, I'm in pain. Like something's going wrong in my life." It could be relationship, it could be something at work, it could be very specific flashbacks, trauma memories. It could be a lot of different things that bring them in. The connection between the issue, the symptoms, and the source of the problem, and how we're going to create a course of action, takes a little bit of treatment planning, kind of like you, I imagine. Like I might just come in and say, "Hey, my hip has been hurting for weeks. Help me." But based on, what we talked about in a previous episode, probably it could be the disc is impinging on the nerve, which makes me feel like it's the hip, but it's not really. It could be, but you see what I mean? Like that,
Yeah.
that's kind of the type of thing I have to first do, is sort of say, okay, what are you coming in with? And a lot of times people who haven't been in psychotherapy will come in and say, like, the people in my life are terrible, right? I'm having a hard time with my boss.
Yeah.
I'm having a hard time with my partner.
Let me
I'm
tell
having
you
a hard
about
time.
why everyone is terrible except for me.
Yes. And that's like, imagine having to start helping them to understand, okay, so as the organism in these environments, you're experiencing these dynamics in this specific way. We have to figure that out with each other, because it could be maybe a lot like what you deal with, which is like, if I have an injury, then I start to adjust my movement patterns, and then that injury continues, right? And so you're having to help me adjust my movement patterns to help me to stave off that re-injuring myself. In some ways, when it comes to relationships, it's the same thing. Like if I'm picking terrible people to relate to because of my history, then yeah, it is those other people, but the role I play in it is I keep picking them. And so that needs to be defined and differentiated. The other thing that might happen is that a person may experience, let's say, a difficult dynamic with their boss. Okay, here's a really good example. My client might say something like, "Yeah, my boss just screams at me and is horrible to me." And so, of course, any normal human being would go, "Wow, that's terrible. Like you should, report your boss, and you should get out of there. They seem abusive." But it sometimes in doing the work, I'm able to see, well, there's a projection happening where the boss is a representation of earlier abuse in their life. They're experiencing the boss as yelling.
So that experience is amplified, maybe?
Yes.
They're experiencing it almost out of proportion to what the actual, I don't know what you would call it, objective experience. What even is truth at this point, right?
There you go.
Yeah.
Yeah. So you got to be
Interesting.
really careful, because I
Yeah.
could lose them, because it's like, it's kind of can sound invalidating. It doesn't mean it's not the boss. That's not it at all. It could still be the boss. They could still be abusive, but the person's nervous system is informing them that they need to run.
Yeah.
And so they might take time off of work, or they might be distracted, or, not able to concentrate at work. And so these symptoms start to pile on.
That's crazy. Yeah. I feel I kind of have known that, but I've never heard it put that way. So nice job.
Thank you.
Well put. Well put. Yeah, the pain is such an interesting topic, and it comes with so many flavors and so much baggage from person to person that it's hard to disassociate that experience from the actual underlying situation or condition, I find. And that's where I think a lot of the skill of what all of us do, I think that's where the skill actually lies, is trying to make sense of that experience that this patient or client is reporting to us, and how that ties into what might actually be going on cognitively or physically or psychosocially or whatever parameters we are working in.
Yeah. And one way I do it in my own head when I'm talking to clients is I think about it as patterns. I think about this as, if there's a presenting issue and this person is coming into my office and going, there's this thing that's coming up in my life, I'm going to be curious. I'm going to kind of take a step back from the issue itself and basically imagine that it's a pattern in the person's life. I'm not here to blame them at all. These patterns develop for good reason in times of our lives when we need to adjust and adapt to our environment. We're always doing that, right? Like, imagine somebody comes in with, what is it called? Like, what is that called? Shortened hip flexors, because they sit all day, right? It's like a necessary evil for what the work that we do, and they're sitting. And so now they have this problem. It's not like you're going to go, bad patient for having shortened hip flexors because you're sitting all day. No, and now you're responsible for managing what's happened as a result of being in modern society where everyone's sitting and doing their jobs. So I think that's the piece that I want to make sure to highlight, is when I'm giving it back to them and going, there's a pattern here that you've been engaged in because you've been coping all your life, and you're developing an awareness around this pattern. It's just super important that I don't lose them to shame and self-judgment, because that happens.
We are always so quick and wanting to place blame onto things, right? One of my favorite quotes is, it's not my fault, but it is my responsibility.
I love that.
Yeah. And I think that goes to everything you and I do,
Exactly.
for the most part, right? So understanding what the situation is and just kind of pushing that blame aside and getting to the, okay, now what? Now what do we do? Yeah.
I used to give this metaphor to my clients all the time. I would say, okay, so in third grade, I had headaches and I was not able to see the board. And so it wasn't my fault that I needed glasses, but it was my responsibility to make sure that I kept track of them, make sure that they were clean, and put them on my face.
Yeah.
Otherwise, I'm the only one who would have suffered.
Yep. I really like that quote. I would be so sad if I didn't throw this out there since we're talking about no pain, no gain. It's sort of a pet peeve of mine at this point to hear the term lactic acid, and that's why people have experienced tissue or muscle pain during exercise. That does not seem to be the case, everybody. If you're keeping up with the literature, it seems we have some good evidence suggesting that that is not the actual pain producing thing.
Oh, cool.
And it's lactate is the transport mechanism of moving fuel around, right? We would see higher levels of lactate to during exercise or activity, moving fuel around to the heart, liver, wherever. But it seems like more of the pain that people may experience is probably due to the metabolic byproducts of breaking down ATP, which would be like hydrogen ions. So then it's purely a pH level thing, acidic and basic thing. And the really interesting thing is, I forget if it's baking soda or baking powder, but you can supplement baking soda or baking powder, and there's a certain recommendation that they have out there, I think, for grams per kilogram body weight or something, and it's a lot. But you can actually supplement with that and do a workout that you would normally do and would be really fatiguing, and you won't experience as much muscle burning pain. And that's, that is a pH thing. So I always found that interesting and wanted to.
So what you're
that
saying
out.
is lactic acid got a bad rap this whole time.
I know.
And we don't know which one is which, whether it's soda or powder, but one of the two can totally reduce it and release it, and then the person can keep working out?
Yeah, not totally reduce it, but I think it's baking soda. I should probably look this
up. Might
up
be a good idea to
since
check
we're
with
talking about this.
good old Chad.
Chad, should we go to Chad?
Let's see what Chad has to say.
Chad, what helps with muscle pain? And I always talk in a robot voice when I'm talking to Chad.
As you should, that's appropriate.
And then, Chad likes to hallucinate too. So, okay, yeah, baking soda. Sorry. Okay, please do not go out there eating and or drinking baking powder, people. Right? But it's sodium bicarbonate.
Okay.
So,
baking
kind of similar to like a Tums, if I remember correctly.
That makes sense.
Yeah, it's basically acting as the buffer against the acid buildup, and it delays fatigue. It allows you to be more tolerant of that acidic buildup.
So let me ask you this then. If I decided, okay, I'm going to go ahead and drink up something, I have to do it before so one of my favorite things to do is yoga. And so before my yoga class, I go in and I do this thing, and a very difficult pose, not a difficult pose, but a pose that's taking a while for me to develop some tolerance around is the wheel. Do you know the wheel?
No, describe the wheel for me. That sounds like a torture device.
It is. It's lovely. It's basically a back bend, and you push up with your arms and your legs. You push your whole body up.
And you do that post-lumbar microdiscectomy is what I'm
Yes, I do.
Okay.
Yes, I do.
Okay.
And then they always do an opposing pose. So I do a back bend, but yes, so we do this wheel pose. It's got a Sanskrit name to it, but I feel like I would butcher it, so I'm not going to try right now. But anyway, so my teacher works us up to it. So we first do a modified, I called it a wheel. I'm sorry. It's a bridge. Sorry, teacher. So first we do a modified bridge. So we actually don't use our arms. We're just doing this thing and we're pushing up our hips. And then we move up to the, you should try it. It's difficult. A lot of people can't do it the first time they do it. But then she'll do, so do it for about 5 breaths, come down 4 times. So do you think that, and I always can do 3, and then my brain won't let me do the 4th one. And we know it's the brain, but I also think there's burning in my thighs and burning in my arms and kind of like pain in my wrist. Do you think that will help me go up for my fourth one?
No, I don't think so. That's probably more of a tensioning situation, a kind of reaching end range type of discomfort. So
Failure? What are these called? To failure?
no, that would be, I mean, yeah, you could call it that from a reaching end range of like a range of motion failure, right? As we imagine the cross bridge, right? As we start stretching, right? So think of little links along these two bridges. So if I've got a link like that, I've got more little tentacles holding on, right? If it's there, I only have what's in between here holding on.
Oh, I
Does that make
see.
sense? So
I
that's why,
see.
if you think of like injury risk at end ranges, that's kind of what we're looking at there, the
Okay.
actin and myosin filaments. But the buffering is more for like high intensity cardiovascular anaerobic movements. Yeah.
Yeah, like a
And
squat.
like a heavy squat that you're doing, 10 to 15 reps of.
Sure. With
Yeah.
weights.
With yeah, like heavy weights.
Yeah.
Or like a wall sit that you're holding for 2 minutes.
Oh, and then you can do 3 minutes.
Yeah. Yeah, it's
That's
basically
cool.
like, I would liken it to you're utilizing the local energy stores within your muscle tissue, and then once you've burned through that, then you need to start getting the ATP from other processes, right? Aerobic, all the transport mechanisms, and that's where you really start to build up the metabolic byproducts. So buffering that against the acid buildup is where you get the value, and that's I was just reading here. This is kind of funny. I think the recommendation is, okay, disclaimer here. Please nobody do this, by the way. But this is what Chad's telling me. Okay. It is 0.2 to 0.3 grams per kilogram body weight. And that is, so to give you an example, that's around 20 grams per 150-pound person. I don't know if you've ever measured baking soda. That is so much. That would be horrible. I don't know how anybody could actually drink that. You asked the question about timing. That's probably something you want to load up, like an hour and a half before the activity that you're doing, so you've absorbed it and processed it and whatnot. But I imagine there's going to be a lot of GI distress with 20 plus grams of baking soda. Can you imagine putting that in like a protein shake? Remember the lava projects in school?
That's what I'm visualizing will be happening in my stomach.
Yeah, that's what I'm visualizing.
And then I do my down dog and it's over.
Yeah. Yeah, so my point of bringing that up is not to recommend people do that. I've certainly never tried it, but it's making the point of, okay, there's clearly something else going on here.
Sure.
In terms of, our poor homie lactic acid and lactate is just doing its job.
I know.
And everybody's getting so upset with it.
Getting a bad rap.
Yeah, it's not a monster, guys. No. It's just a car.
It's just a transport.
Yeah, it's just lugging things around.
Yeah.
So I find that very rude, and I wish people were more respectful of lactic acid.
Yeah. Well, after this episode, I am.
You are more respectful? Then perfect. I've done my job.
Your job here is done.
Yeah. Well, I was interested to get your thoughts on the no pain, no gain. It just because it frustrates me a lot when I hear that. But any other comments you want to make about that very common patient?
Yeah. So I have a couple things I just want to kind of point out there. I want to give you all a definition of the word overwhelm.
Ooh, good.
And given the fast-paced world we live in, I think the concept of overwhelm is actually pretty overlooked and underestimated. Because I think a lot of people are actually living in a state of overwhelmed and not realizing it, thinking that they need to. So this I found off of good old internet. When someone feels overwhelmed, it means they are experiencing a sense of being burdened or unable to cope with too many demands, responsibilities, or strong emotions. It's like being flooded with thoughts, feelings, and physical sensations, making it difficult to manage the situation. This can lead to feelings of stress, anxiety, or even a sense of being paralyzed. And I also think what has happened is that there is an expectation that we should be able to do a lot, accomplish a lot, manage a lot, be really sweet while we do it, be kind, be generous, make
Yeah, the
sure you're
hustle culture.
completely,
Yeah.
completely. What this is saying is that we all have limits. And when we reach those limits, we will have symptoms. And the worst thing you can possibly do is then judge yourself as weak or bad, or you can't keep up, or there's something wrong with you. That just further perpetuates the problem, leading to depression, leading to anxiety. So I guess I wanted to have my own version of a PSA that when you hit, before you, the key is to know yourself well enough before you hit overwhelm.
Yeah. Would it be safe to say don't change the limits, change the tolerances?
What do you mean?
So when you're saying, okay, there are these external, maybe even internal forces that are causing an overfilling or burdensome emotion or psychosocial state,
Yep.
could we say, okay, we have a spectrum of tolerance, and if we do some work to change that tolerance level, can we then take in and tolerate more? And would that be beneficial, or is that kind of silly and we should look more at the external factors and try to limit those, or do both?
I think it's a matter of both. Unfortunately, I think in this society, since we're constantly thinking about better, faster, bigger, accomplishing more, doing more, fitting in more, I think that I don't want the message to be that you have to be able to tolerate more. Because if anything, I think the wisdom is in knowing your limits. So knowing that, by the end of the day, I shouldn't be working into the wee hours of the morning because I've got to accomplish tasks, whether I am 44 years old or 14 years old.
Yeah.
Like that sleep is important, and taking breaks to feed oneself is important, and engaging emotionally with friends and family is important, and not pushing through in order to be better or to be perfect or to be the best.
Yeah, that's I love how it's so telling about me and our culture that I immediately went, okay, but what if we changed how much we could tolerate?
I know, Adam, and that's fine. I'm right here with you, buddy.
Oh, damn it.
It's so great. You fall right into it every time. And then I'm like, Adam, it's okay.
Oh man. Yep, I am the standard American man at this point, right?
Well, you're a good representation, right? That folks can trust you, and that you yourself are willing to be, to
Reflective.
be reflective and go, oops, like it's so built in, it's innate.
Yeah.
It's become so innate in us. But again, the problems come up, right? Like again, back to the computer. Like if I'm hunched over like this all day, for therapists can get therapist neck,
Yeah.
where
I
we're
love how every
jutting.
profession they claim that, forward head posture. My brother is in tech. It's called tech neck there. Yes. Sorry,
Exactly.
what were you saying though?
But no, that it's part of the world we live in, but to self-correct, to know your limits, to know what you need that's really a big part of this conversation too, about no pain, no gain, because sometimes that pain is information. And how do we get to even before the pain?
Yeah.
You know?
Our body gives us so many clues. So
Yeah.
many clues. We just got to listen. All right. I love it. That was great. I appreciate your experience. Are you ready for silly question time?
Yes, let's do it.
Okay.
I love that this is back.
Yeah,
I've missed it.
I'm bringing it back. I'm never going to let it die.
Good.
Oh, there's so many good ones here. These might take, and I'll ask it, and then we can move on if you feel like it's going to take too long of an answer. But here's a good one. If you could diagnose anyone in history, who would it be and why?
You're asking that question now?
Do you want to answer that one, or here's another one. Let's see. If muscles could talk, which one on you would be the sassiest?
Ooh, I'll do that one because
Okay.
the other one would have taken forever.
I
I would
know,
have
yeah.
cried. It would have been the thing.
That one's deep. Yeah.
Let me think about my sassiest muscle. I think my shoulder muscles right here, what are they called?
Your upper trapezius.
Yeah. They're really hot. Can I say that?
Why not?
And I remember when I was lifting.
Wait. What do we mean by they're really hot? Like
they're just really, really confident.
you like you're really proud of your upper trap specifically.
Yeah.
Like if I was like, all right, Pegah, I'm gonna rate what you love most about your body.
Yeah.
You'd be like upper traps for sure.
Yeah, and then upper trap and like kind of right here, this combination. I know you can't see it on camera, which is probably a good thing, but especially when I used to lift, like deliberately lift, which my old trainer, if he's probably like, why aren't you back in class? But yeah, I felt like I actually was very strong here. And something about that, I probably shouldn't be too proud of it because it also probably means that I carry the weight of the world on my shoulders now that I think about it, because #therapist.
Here we go.
Damn it.
Here we go.
But I think she's gotten me through these sassy muscles have gotten me through a lot of life. And
sassy
I'm very
traps.
Sassy traps.
I love
That's
it.
me.
Yeah.
What about you? What you got?
For my sassiest muscle, I'm so tempted to name some random muscle to like show how smart I am and how much I know. But I'm just gonna go with the erector spinae group.
I think you nailed it.
Yeah.
Adam.
Stand up and deliver, y'all.
So what is an erectus?
It's the muscles on the back that hold our spine up.
Nice. Yeah.
Google it, guys. Google it.
They,
I'm gonna make we're gonna start making Take 3 and Call Me in the Morning merch. And the first one is gonna be sassy traps.
Sassy traps.
Yeah. It's gotta be a tank top obviously, but
Yeah.
sassy traps.
Yeah, because you got to show.
Yeah.
You got to show these sassy traps.
Amazing.
And it's the bumps, right? It's the hill, the valleys and hills that are created. That kind of. This is how you know how little defined muscles I actually have on my body.
I don't even know where to go with that at this point. But I love it. I love it nonetheless. Well, awesome. All right. On that note, on sassy traps and lovely bumps, time to go. Thank you, Pegah.
And erector spinae.
Erector spinae. Goodbye, everybody.
Goodbye.
Thanks for spending some time with us today on Take 3 and Call Me in the Morning. We hope today's conversation gave you something to think about. If you enjoyed the episode, consider subscribing, leaving a review, or just sharing it with someone who you think would appreciate it. If you want to learn more about us and our individual practices, you can check out Pegah's practice on her website, livingfullytherapy.com. If you're interested in Adam's physical therapy practice, you can learn more about his practice on his website, equalizerhealth.com. And if you want to know more about my practice, you can go ahead and check us out at healthyconditions.com. Just a quick reminder before we go, remember this podcast is for informational purposes only, not intended as medical advice. So please talk to your healthcare provider about what's right for you. Until next time, and don't forget, be kind to yourself.